We are honored this morning to have Lloyd Alterman give his perspectives on the quote WISeR program that CMS is trying to institute. Um, Lloyd is a retired internist, nephrologist, active in health justice for 10 years, and has been on the board of One Payer States. Member of many other organizations fighting for single payer. Lives in, he is the chairman of the New Jersey Universal Healthcare Coalition. And Lloyd, tell us your perspectives on this WISeR proposition.
Let's call it a boondoggle for want of a better word. Um, so, thank you for the opportunity to speak to everyone today. I asked Mike to allow me to do this, in part to get the ideas of the membership as well as to give you my own ideas. And I'm going to divide this talk into three parts. First, I'm going to discuss a bit about how Medicare payments have come to be what they are today. Secondly, I'll get into the nuts and bolts of WISeR. And thirdly, we'll talk about what we have been doing so far and what we hope to do between now and the end of December to get this program either delayed or hopefully abolished altogether. Okay. So WISeR is an acronym that stands for Wasteful and Inappropriate Service Reduction. And by the end of this talk, I hope to convince all of you that WISeR is not wise at all. Healthcare costs have been rising since the 1970s, and they started to go up exponentially toward the end of that decade. That would have been a wonderful time for the United States to embark on a universal healthcare program, the way the vast majority of the 38 other OECD nations have done. But that did not happen in the United States, partly because we had a Republican president in the White House, partly because you can't get Congress to agree on anything, even back then, and partly because the physician community was against it. And nobody could be convinced that the government might be able to do a better job of taking care of us than the private sector. So basically, the government said to the health insurers, we're going to rely on you to lower our health care. You're going to be responsible for controlling costs. And what ensued after that was an alphabet soup of acronyms. We had the HMO, where a given group of healthcare professionals would take care of a narrow network of patients and basically be responsible for financing the care of that group of patients. The term capitation became popular. Capitation, as you know, is the payment of healthcare providers sort of before the fact. They get a per patient per month um, revenue stream. And with that money, they basically provide the care for all of the patients that are in their particular network. Um, the concept being that if you can spend less money on the care than you are taking in, you can keep part of the savings. And that, of course, created an incredible conflict of interest among physicians. And I myself was part of that in those days, and I didn't like it one bit. Um, in addition to the concept of managed care for doctors, we had another entry into the mix, and that was prior authorization. And insurance companies would hire staff to basically manage doctors to make you call up their 1-800 number and get permission to perform whatever procedure you were looking to do on a given patient. And before they would even agree to reimburse you, you had to get their approval first. Well, those things were all part of the commercial healthcare milieu, but um, the Medicare population basically did not suffer the slings and arrows of this. Um, Although, of course, Medicare at the time was not particularly popular among doctors, simply because it did not reimburse very well, and commercial carriers reimbursed far better in those days. And I would say that in the last 10 or 15 years, there's been a narrowing of the gap between what Medicare is paying doctors and what the private sector is paying doctors. So that becomes less of an issue. And what becomes more of an issue now is the burden of having to deal with prior authorization in a given population. So, as I said, Medicare basically was sort of floating under the radar screen until the Medicare Modernization Act of 2003 under the Bush administration. And this is when Medicare became a fully fledged managed care entity, um, unfortunately for us. We created Medicare Part D at the time so that uh, pharmacy benefits for the first time, at least for certain generic medications, would be covered under the Medicare system. But they did not allow Medicare to negotiate drug prices, which became quite a bit of an issue. And of course, the Medicare Modernization Act created Medicare Advantage so that Parts C and D could be used by so-called Medicare Advantage operators to provide all the benefits of traditional Medicare in a private sector format. And don't for 1 minute be confused that that's truly Medicare. It's really private health insurance wearing a Medicare costume. And that's where it still is today. Um, Unfortunately, they do a very good job of marketing, especially during open enrollment periods. I know you cannot escape getting these commercials, listening to them and having them talk about the benefits of signing up with their particular Medicare Advantage plan. And this goes on every year. And there's really no need for that. It's wasting a lot of money and it's creating a lot of confusion among the populace. A whole cottage industry, if you will, has developed these so-called Medicare consultants whose job is simply to talk to people and try to convince them to join one particular Medicare plan or another. Um, all of these things are money spent on other than patient care. Um, the one good thing that the Medicare Modernization Act may have done is to provide for health savings accounts, and that's I think something that is not is something that I think is worthwhile. Um, and then, of course, as time went on, the Medicare Advantage operators learned how to game the system. Every year, they would have to submit a bid for how much their capitation benefit would be per patient per month. They would be able to stratify for risk. If they took care of a more risky patient population, they would be able to increase their revenue. And all sorts of games were being played. The Medicare operators would, as you know, cherry pick and lemon drop. They'll find the healthiest patient population and they'll try to make them look as sick as they possibly can. They'll market in things like square dances. They'll market on second floors of venues, which are walk up, to make sure that they are capturing the healthiest of healthy. Uh, and of course, while they're doing that, they're upcoding the charts of these healthy patients to make them appear sicker. And this was going on year after year. Um, the Kaiser Family Foundation, KFF, has estimated that overpayments to Medicare Advantage operators were anywhere from 22 to 39% higher than traditional Medicare enrollees. This amounts to like 80 to 140 billion dollars per year, which is a lot of money. When I get into WISeR and exactly what it is, I'll mention to you that WISeR is designed, at least in its first year, to save maybe 10 to 20 billion dollars, which is a drop in the bucket compared to what savings can truly be realized if we were to attack the Medicare Advantage operators the way they should be and rein them in. The Affordable Care Act came along, and that really didn't affect Medicare very much. It had more of an effect on Medicaid, of course. And states that were willing to expand their Medicaid population um, were surprised to see that the number of uninsured in their particular states went down from about 16% to 12%, which is quite a reduction. There were a few states that did not agree to expand their Medicaid enrollments, and that's quite unfortunate. Um, of course, the Affordable Care Act was impugned by Republicans. Trump campaigned on it to a great extent in 2016. He felt that the Medicare mandate, the fact that, or not Medicare mandate, but the health insurance mandate that required everyone to purchase health insurance, whether they wanted to or not, uh, he felt that was unconstitutional. Of course, the Supreme Court did allow it. But ultimately, in the Tax Cut and Jobs Act of 2017, that was that they put the scuttlebutt on that. So now we're dealing with, of course, the big beautiful bill, or as Barbara Pearson termed it, I think quite aptly, the big beastly bill. And now we're seeing that, of course, the major reason we're having a healthcare shutdown today is over healthcare and the Affordable Care Act tax credits and the changes in the Medicaid provisions. I think while it's very laudable that the Democrats are fighting for this and fighting to maintain the Affordable Care Act tax credits, really what we're doing is filling potholes. And what we really need to be doing is building a new road. And unfortunately, we're still quite far away from that, I think. So, in summary, we're now dealing with a healthcare situation where more than 50% of Medicare enrollees, excuse me, are enrolled in a Medicare Advantage or Medicare Part C plan. Um, some patients do like it. For one thing, they do not have to purchase a Medigap policy. Some people are healthy. They really don't need a lot of healthcare coverage. But the more ill one is, the more likely it will be that this will not be the right plan for them. And sometimes people find that out a bit too late. So the major downsides of the current Medicare Advantage programs, in addition to the fact that it's draining our Medicare trust fund and costing taxpayers billions of dollars a year, is the fact that there are narrow networks and the fact that prior authorization is required for quite a number of medical procedures that in traditional Medicare, prior authorization is not required in. So we come to what's going on now with the WISeR initiative. And what is WISeR exactly? It's a pilot project that CMMI, which is a branch of CMMS, Center of Medicare for Medicare and Medicaid Innovation, has embarked upon in the hopes that money can be saved by asking Medicare providers who are taking care of traditional Medicare patients to pre-authorize 17 specific procedures that they have identified as low value. It's scheduled to begin January 1st, 2026. It's going to operate in 6 states, those being Arizona, New Jersey, which is why I've gotten involved in it, Ohio, Oklahoma, Texas, and Washington. And this is about 1/5 of Medicare enrollees that are going to be affected. Now, historically, as I mentioned, traditional Medicare did not require prior authorization except on maybe a couple of 100,000 specific cases a year, things like non emergency ambulance transport, some other somewhat esoteric procedures like deep brain stimulation for Parkinson's disease and what have you. Well, in their infinite wisdom, CMMI has asked for 17 procedures that really are quite commonly performed in the Medicare population. I have the complete list here, but I'll just highlight the fact that hernia repair is going to have to require prior authorization, epidural steroid injections for spine pain, um, transcatheter aortic valve replacement. Now, here's something that revolutionized healthcare. Um, Before the advent of transcatheter approaches to aortic valve repair, one would need to enter the hospital for a week, 10 days, have open heart surgery, go on cardiopulmonary bypass. This was incredibly expensive and time consuming. Um, it took up a lot of physician time, ancillary personnel time. And now, with the advent of TAVR, as it's known, one could go into the hospital and spend an overnight and come home with a result every bit as good as that's been achieved with open heart procedures. So I hardly consider something like that wasteful and inappropriate care. And yet somehow it wound up on the list of those procedures that are going to require prior authorization. So how is this going to work? Um, the 6 states are going to be hiring artificial intelligence companies who in turn will be managing the prior authorization process. And they're going to be using predictive analytics um, to make initial determinations on whether or not a patient's care is appropriate, whether it should be reimbursed, or whether it should be denied. Now, let's talk about these prior authorizations for a moment. As I mentioned, in traditional Medicare, only about 250,000 prior authorizations were required in 2023. Um, with Medicare Advantage plans, over 50 million prior authorizations were required. It's quite a difference. And of those, 6%, or about 3 million, were initially denied. And only 10% of those were appealed. When you think about it, it takes a lot of work to appeal a denial. A physician needs to hire staff to do that or spend time on the phone themselves to do that, which takes time away from patient care. Essentially, it creates hurdles and burdens for healthcare providers that really should not be there. Um, well, those denials that were appealed, the 10% or so that were, about 80% of them were ultimately approved anyway. So basically, just about every particular or every particular procedure that had been denied was ultimately approved, suggesting that maybe the initial denials really weren't done very well. And only after going through all kinds of machinations and jumping through hoops, eventually these procedures were improved. And this, of course, delays care for patients. It creates hurdles and just hassles for doctors. And I'm a firm believer that care delayed is equivalent to care denied. And some of these poor patients probably never got the care they needed simply because their pre-authorization weren't done properly or to the liking of the plans. So not only is traditional Medicare for the first time going to require prior authorization, it's being done in a very novel way, and that is using artificial intelligence. They're not hiring physicians to make these determinations. They're hiring AI companies to do it. And we know very little about the algorithms that the AI companies are going to be using. All we know is that ultimately, if they are initially denied through AI, they will have to be subject to a physician review. but it's the AI companies that are going to be hiring the physicians to do the reviews, not CMMS. So again, this creates a conflict of interest to the doctors who are going to be doing the physician reviews. It would be to their advantage to deny care, and yet that's really not what we're looking to have happen here. Um, we already established that just about every case that's initially denied will ultimately get approved in the long run. Why do we have to go through this intermediate step that just takes time, takes effort, takes money? It just totally drains our healthcare budget for absolutely no good reason at all. And the amount of money that is at least projected to be saved in the first year of the WISeR initiative is somewhere in the neighborhood of $10 billion. dollars. I already mentioned to you that every year Medicare Advantage operators are bilking the system and draining the Medicare Trust Fund by over 80 billions of dollars. So the savings to be gleaned from this intrusion into medicine is maybe going to amount to 10% of what we could really save if we were to go after where the problem really lies. When Kennedy and Mehmet Oz appeared before the Senate committees for their confirmation hearings, I think they both gave lip service to the idea that we were going to try to stem the prior authorization requirements in the Medicare Advantage plans, and everybody agreed that this would be appropriate. Um, and yet now here we are. While they're doing this, they're at the same time trying to start prior authorization in traditional Medicare. It just makes no sense. It's like they're playing tug of war with themselves, and I don't get it one bit. Um, so uh, that's the WISeR program essentially in a nutshell. Um, it is a burden for physicians. It's going to make patients very angry when they find out that the doctor can't schedule a procedure until they call that 800 number and get their authorization churned through some sort of a artificial intelligence algorithm. It's going to create a lot of ill feelings. It's going to destroy the doctor-patient relationship, whatever's left of it. And it's certainly not, in my opinion, or the opinion of just about all doctors, and I'll get to that in a minute, um, a benefit and something that we should really go forth with. So that brings me to part three of this talk. What are we doing about WISeR? Well, so far, quite a bit actually. When I first started investigating things, I was under the impression that this was truly floating under the radar screen, that physicians weren't aware of it, that they were going to find out on January 1st, 2026, that all of a sudden this is hitting them in the face and that they were unprepared. Um, well, as it turns out, that's not true. More than 20 surgical societies have already written letters to Doctors Oz and Abe Sutton, who's the assistant director of CMMS, who actually heads the Center for Medicare and Medicaid Innovation. All of these surgical societies have come out against WISeR. The American College of Surgeons has come out against WISeR. The American College of Physicians has come out against WISeR. Even the American Medical Association has come out against WISeR. And in fact, I should mention that in next Wednesday night, the AMA is sponsoring a webinar where the guest speaker will be Abe Sutton, who is the head of CMMI, and he will be answering questions from the audience about WISeR. One does not have to be an AMA member to register for this webinar. You can go to the American Medical Association website and sign up for it. They'll obviously ask you to join the AMA, but that's certainly not a requirement. And I'm looking forward to hearing what Abe Sutton has to say and the questions that he gets about this boondoggle that they're trying to enact. What else are we doing? Well, Congress has actually gotten involved to some extent. In July, 48 US representatives have gotten together and under the leadership of Representatives Lloyd and AOC, uh, signed on to a letter impugning WISeR and asking that it not be initiated. That's 48 Congress people, and that's a reasonable amount. On the Senate side, a similar letter was written, and we got 18 co-signatures on that letter. Most recently, Representative Mark Pocan of Wisconsin has introduced a resolution into the House, um, again indicating his opposition to WISeR and basically asking all congressional members to sign on to this in opposition to the WISeR program. Um, I want to give a shout out to Anna Malinow, who has organized a number of states who are being affected by the WISeR program into a task force, which I've been a privilege to be a member of. We had one meeting, and we're having another meeting later this evening, which is another reason why I wanted to speak today. Um, we have members, I believe, from 5 of the 6 states. I don't know, Anna, if you want to just chime in. Have we gotten somebody from Oklahoma yet? I
Yes, yes, we have. We
Oh,
have.
wonderful. Okay,
Yes.
so now we have all 6 states represented on this task force. And what are we doing? Well, we are each reaching out to our constituents in our own individual states. I've written notes to the New Jersey Universal Healthcare Coalition listserv several times, urging them to write to their Congress people and write to Mehmet Oz and Abe Sutton specifically, and I'll give you their addresses in a moment. Um, we've got to put a stop to this program. Um, I've written an op-ed. I know several other members of the task force have written op-eds, and we're hoping to get them in local papers and on websites. We need to create a groundswell of opposition to the WISeR program. Um, and I think all of you can play a role, even if your state is not currently one of the 6 states that are in the initial tranche of participants. Eventually, the idea here is for the WISeR program to expand and cover other states. Undoubtedly, it will expand to cover other procedures. And what we're doing is taking traditional Medicare, the last vestige of what might be considered a public service and a public trust, and we're just putting the kibosh on it. I can't say it's being privatized. It's not exactly what's happening. But prior authorization, as I've mentioned, is one of the most sinister aspects of privatized Medicare. And to start doing prior authorization on traditional Medicare patients, I truly believe is a step in the wrong direction. Um, so, as I said, we are active on this task force. I don't see him on the call today, but Robbie Stern of Pisara has really done yeoman work in Washington, talking to their constituents and to the representatives and congressional representatives in Washington. I know in New Jersey we have both senators who've signed on to that opposition letter. I've already spoken to several Congress people and their staffs, and I've given them an earful about WISeR and what I feel are the negative aspects to it. And I'm sure other members of the task force have been operating in their states in the same way. So I'd like to just get some thoughts of those on the call today. If you can come up with any other ideas about what we might focus our task force on over the next 2 months, because we have a very short time frame to operate in, and we really would like to get as many people hearing our message as possible. Um, Mike, if I could just sort of open it up to everybody who's on the call today to maybe chime in with their opinions, put them in the chat or speak or however you want to address this, and certainly ask me additional questions at the same time. I'm certainly happy to answer them to the best of my ability.
Yeah, thanks. Thanks, Lloyd, so much. Very concise, compelling presentation. Before we start Q&A, just to remind everybody about the norms that we follow here, and that is to be as concise as you can with your question, um, and just take care of each other. Avoid anything that sounds demeaning to anyone, whether they're here or anywhere else. Um, and let's go. I don't see any hands.
Before I entertain any other thoughts, Anna reminded me in the chat to mention how the AI companies are being paid for this. They are being paid by commission. The more they deny care, the more they profit by denial of care. This is perverse, to say the least, and it is just not the way we should be doing things in the richest country in the world. The other thing I really do need to mention is the address that one can write to Mehmet Oz. I'll put it in the chat, but just if you want to take it down, they're both in the same location. It's 7500 Security Boulevard, and that's Baltimore, Maryland. And I'll get you the zip. I believe it's 24221, but I will get you that and I will put it in the chat because I think it's important that all of us write to Doctors Oz and Mr. Sutton, giving them a piece of our collective minds. So with that, let me open it up to others.
So you can pick people lined up, Bill, and then Barbara and
Okay.
Ken.
All right. I don't see, oh, I see one hand raised, Carla. I don't
It's
see.
Bill. Bill Simple is
Bill,
first.
Bill Semple, please go right ahead.
Okay, thank you, Lloyd, for doing this important work. One thought, a question I have is wondering, is there any traction to be gained by calling this practicing medicine without a license? I mean, it seems to be that's
I'm
exactly what it is.
It really is. I mean, all of prior authorization can be considered practicing medicine without a license. And when an AI chatbot or algorithm is doing it, I shudder. I think you're absolutely right. I don't know how that would stack up in a court of law, though.
Hmm.
They would argue that they're not practicing medicine. This ultimate decision is always yours, doctor, as they say.
But it might be a way in the court of public opinion.
Yeah. Oh, of course. I think that's a great idea. Thank you. Yeah.
And then Barbara's
Um,
next.
okay.
Yeah, I'll be
Barbara
quick.
Pearson.
Yeah, I'll be quick. Thank you, Lloyd. I just wanted to share a couple of years ago, I did like a blog for the League of Women Voters newsletter, which I'll send to you and Anna if you'd like it. But it was about AI. All of a sudden, AI denials just surging to about as many as 150,000 a month. And the what I wanted to make sure you saw was a quote from um, their internal documents. So although the Cigna legal department said, "Oh yes, of course it's safe, and patients can always do things. We're not harming anybody. Um, they can always appeal." And what harm has been done if we deny it after the thing has already been happening? Which seems really cruel. But one of the things that they said was that they acknowledged that it could create a negative customer experience and a potential for increased out-of-pocket costs for patients. But the company opted for greater efficiency and profit. So with deny and appeal, they make tons more. And they recognize that.
That's just awful. Thank you for that. How about some thoughts on how the task force might put its collective head together and anything else we can do? I should mention I've written to the New Jersey Commissioner of Banking and Insurance, and I believe some other states have contacted their insurance departments as well. Although, frankly, I'm not sure how a state agency can affect a federal program. I don't know if they have the option to refuse to to follow the federal law. But in any event, it's certainly another one of the things that we've been sort of kicking around in the task force.
Barbara Harrison is up next.
Yes.
Barbara?
My concern is that people in underserved communities, rural communities, communities of color, working class communities need to have information about what is going on. How would you, and I have found this as somebody who has worked in single payer healthcare up here in New York in Ithaca, people, the progressives, they don't want to go out to those communities. What are your thoughts on getting to those people? How important do you think it is that people know about this? Thank
I
you
think
so much.
well, it's vital, that they do. I'm not sure how to solve that particular problem. The only thought I could suggest at this point is maybe to go to church groups or other houses of worship to try to get maybe the organizations such as NAACP involved, other racial justice organizations to get them aware of it. There's a lot. There are a lot of conflicting needs and issues that are going on today, unfortunately, and WISeR is really not up there on the top of the list, unfortunately. But I do present it here today because of the boondoggle that it is, because of the problem it's going to cause for the physician community, for all of the Medicare patient population. But yeah, in terms of getting others engaged and not only engaged, but inspired to do something about it, that's one of the things I've been fighting for the past 10 years. And that's one of the reasons I wanted to get some other ideas and opinions from this call. Maybe you have some thoughts or things you've done that worked that you can share with the group.
I have not been able to get, I wrote a storytelling workshop, which I think creates a wonderfully level playing field. And unfortunately, the people here in my community, they weren't interested. To quote, we're not interested in your issue. So it's very sad. And Indivisible, which I went to once and asked them if they would give me some direction on forming a single payer group, I never got any response from anybody. And again, it's the same composition of just people from Ithaca. There's no impetus for them to go out. And that's really rather broken my heart. And I've rather kind of withdrawn from everything because what you're saying is what I've written in my storytelling workshop. And lack of community seems to be prevalent. Crossing ethnic, class, and cultural boundaries is not something that
We have Barbara
I'll
and
let
others.
someone else go.
We have 5 people lined up. Ken Dockert.
Yeah, yes, thank you. Can you hear me? I've got these
Yes.
earbuds in. So, thanks, Lloyd, for presenting this topic. I'm a physician, a geriatrician. I take care of elderly. All my patients have Medicare. Actually, in rural New Hampshire, I'm at Dartmouth, which is actually a rural academic medical center. And by the way, we have at least 2 or 3 Medicare Advantage plans pulling out of New Hampshire. You don't make a lot of money in rural states. So you guys, where this is being laid out, is where currently Medicare Advantage is making most of their profit. I guess I'm not taking a contrarian perspective, but I want to bring up the issue that every universal single payer system in the developed world does have an evaluative system in place to look at what procedures are worthwhile, what procedures have scientific merit, and which don't. So you have NICE, National Institute for Health and Excellence in Britain, for instance, that will determine this medication should be covered. That procedure should not be covered. I was surprised to learn that TAVR is being evaluated as one of those questionable procedures because as a geriatrician, so many of my patients had critical aortic stenosis. This is a life-saving, really life-changing procedure. However, many of the other things on the list are of uncertain benefits. So epidural steroids or whether vertebral kyphal, etc. There's a lot of things on that list that are also probably would get some degree of review anyhow. So I think my perspective is that we have a society that no longer wants to have, the U.S. Preventative Task Force weighing in on things. These are considered left-wing projects. They're not. They're obviously science-based projects. But what's being happening here is an effort to privatize what is the responsibility of Medicare. And I think the focus shouldn't be, oh, doctors should not be said that this procedure is not worthwhile when the scientific evidence proves that it's not or questions it. It's who is doing this. And as you brought up, the profit motive, commissions to deny a procedure, that is anathema. That is totally opposite to any rational program. So my opinion about this is that that's where the focus should be. It shouldn't be that, bladder, that vagus nerve stimulators or this, that, or the other electrical spinal stimulators, they may or may not have merit. CMS has always looked at this. I think the focus should be who is making a profit off of this, why, and who used to make the decisions, who's now going to be making those decisions. And so that's a comment I wanted to bring.
I agree with those comments. I think they're very well taken. I would feel a lot more comfortable with this upcoming initiative if it were physicians who are being paid independently of the outcome of their decisions, making the decision on what should be approved and what may not be worth doing. Certainly I agree. We can't spend our limited healthcare dollars on every single healthcare need known to mankind. I mean, that's just not feasible. What's so perverse about the WISeR program, though, is how they're making these decisions on who not who shall live and who shall die, but who will be authorized to have certain procedures versus who will not. I think that's expressed very well. I think all of you who signed on to this call have access to a copy of an article in the New England Journal of Medicine. It actually came out in print just this week. It's been available online for a couple of weeks now. Basically, a proliferation of prior authorization in traditional Medicare, none the wiser. And the authors make the point that, yes, we need to rid the Medicare system of waste, fraud, and abuse. Yes, we need to make sure that our healthcare dollars are spent appropriately. But using artificial intelligence to do that as an initial screen just doesn't pass the smell test, to me anyway. And since I'm discussing the use of healthcare dollars, let me remind everyone that with traditional Medicare, 98 cents of every dollar spent is spent on direct patient care. It's very low administrative costs associated with traditional Medicare. With Medicare Advantage, it's more like 85 to 90% at best that's spent on patient care. All the rest of that money is going to the income of those who work for the managed care operators, for advertising. Why do we have to watch Joe Namath talk to us about your Medicare plan when in fact the money that he's making on this can be spent on your Medicare plan? That's the simplest way I can put it. But to get back to your comments, I do agree. We have to have some way of determining what is appropriate versus what is not.
We have three people lined up. Lloyd, next is Carla, and then Ann, and then Anna.
Okay, great.
Okay, this is Carla in Minnesota, and I might be pretty naive about these pilot projects, but just exactly, are they just a given that it's going to be successful, or who is going to evaluate it and decide, or are they just a given?
Well, they can't a priori know in advance that it's going to be successful. I think they're predicting that it will be successful, but it's going to have to be subject to scrutiny itself. And I don't know how they're going to do the evaluation of the program. I suspect that's one of the questions we could ask Abe Sutton when he appears on this upcoming webinar. Um, how will we know whether it's done its intended job? And again, why are we focusing on this as opposed to the drain on the Medicare trust fund that managed care entities have caused for the past 10 years? I think those are the key questions that they have to answer.
And next is Ann Jones, and then Anna.
Yes, exactly right, Dr. Alterman and Dr. Dahlgart. I think we need, so PNHP is making this one of the lobby day, the advocacy day issues on November 3rd, and it's great to get the physicians involved up front. The AMA, I'm a nurse, retired, working on health policy stuff. What I think we need to educate, so Congress doesn't get to vote on this, but they can stop it, I think, as Mark Pocan's trying to do. They can push back. They don't get to vote on approving this stuff because CMMI can just do whatever they want as a internal so-called innovation shop in CMS. But the thing we need to educate the public and our members of Congress about is, again, if you want to save money, if that's really your goal, then the fraudulent overpayments, look at that. Clinical specialties, as Dr. Dahlgart explained, need to do their job in vetting procedures and treatments, and then look at prices. For like, there's apparently one of those items is that a biologic that's a skin repair treatment, and the price is outrageous. I don't know how effective it is. It's for diabetics primarily. The price is outrageous. Go at that. This is the wasteful and inappropriate use of your regulatory power to go use a backdoor approach to saving money instead of the front door, which is really looking at real costs and fixing and preventing. So that's my take.
Great, thank you. Those are great comments as well.
And then Anna's up next.
Okay.
Well, first of all, Lloyd, what a great presentation. Thank you. I learned a lot. And I think that I know quite a bit about WISeR, but just like with all of these boondoggles out of the CMMI, once you think you understand some of it, there's always more corruption to try to understand. So a couple of things. One is that first of all, Len, I love that spherically offensive line. I will definitely use that. That's very. So CMMI was a creation of the ACA. So even while the ACA, I think you said that the ACA didn't really affect Medicare, it really affected, well, it opened up the floodgates to Medicare Advantage, but it really affected and targeted traditional Medicare because that's where CMMI sits. The ACA created the Medicare Shared Savings Programs plus the Medicare, the Innovation Center, CMMI, which was given $10 billion every 10 years, no matter what. So whether they control costs for Medicare or not, they're still going to be getting their $1 billion every year to create these models. And the CBO had a report on the first 10 years of the CMMI, whether they saved money, any money from Medicare. And in fact, they found that in the first 10 years, they overspent by $5.4 billion, and that they're on target for overspending in the next decade. So no, these models do not save money for Medicare. And why? Because they are privatization. What they do is they insert profit-seeking middlemen into traditional Medicare where they did not exist before. So the problem is that Congress has no authority to stop these models. They don't. And even Pocan's bill is not really a bill, it's a resolution strongly urging CMMI not to run this project, this pilot project. I think that it's important. It's the very first time that Congress has actually even written a resolution against one of the CMMI models. So it is important for us to get out there and to use this as an education tool for our Congress people as well as for the public. But unfortunately, Congress is not going to be able to do much. The only thing that I think they would have to do is to write a law to end CMMI. But really, if we're going to go that far, the law that they need to write has already been written, and that's Jayapal's. And I think that that's really what they need to pass. They need to pass, Medicare for all. So, and then to the other comment, and I'm sorry, I don't remember Ken Dolkart's name, is that waste, fraud, and abuse definitely exists for sure. But too much care actually only probably like too much inappropriate care probably only contributes about 10% to the total overall waste in the United States. So, actually 18% of our wasted dollars is due to too little care. So but the biggest amount of money that is wasted is on administration, which is required to generate the profit for our profit-driven healthcare system, as well as prices, which is what Anne brought up. So lots and lots of really, really great information here. There were a couple of other things that I wanted to mention, but I think that's it. Thank you. This is really great.
Thank you, Anna. Thank you.
Can I jump in and just Anna, thank you. I agree with you totally, by the way, in terms of where the actual wasted dollars are going. It's administration and pricing failure, among other things. One thing about the legislation and putting a rein on CMMI, there is a revolving door between the insurance industry and CMS. It is wide open. The folks who are basically working for CMMI had previously been insurance executives and vice versa. There has been legislation to limit such action in the defense industry for whatever good that did, and other industries to actually prohibit that revolving door from being that wide open. So I think that's part of the problem. And Congress does have an ability to limit that, if not the actual actions of CMS. So thank you, I agree.
Thank you both. Those are great comments. I agree with you, Anna, that we can't change what CMMI is going to do, but we do have public opinion that we can manage. And if there's a way that we can get enough people to support our cause, to fight against WISeR, it may change some minds at least. It's not going to change any laws. But so that's really what I think our goal should be for the next 2 months. Remember, we only have 2 months here to work on this, and we have to come up with some sort of a concentrated plan to fight this while we still can, or I don't know if we can fight it, but fight it while before it's actually become a fait accompli, at least.
So Lloyd and Anna, Ken, thank you all for your comments. I just want to make sure everybody understands this program is sponsored by One Payer States, and you're very welcome to donate. And also to point out that National Single Payer and One Payer States are both fighting tooth and nail to reach universal health care. And so support National Single Payer as well if you agree with their point of view. But boy, both of us, let's go for it. We absolutely are united on the opposing the privatization of all of our healthcare. That's our main goal, and we want to make sure that everybody knows One Payer States that's the ultimate goal is national single payer universal healthcare. We have Catherine next.
Thanks, Lloyd, for this information. I really appreciate it all. I'm just hoping maybe I can indulge everybody really quick with a question that is slightly unrelated, but related to the current issues going on. And that's regarding the pulling back of the enhanced subsidies. And my question is, like, I only know one person who bought their insurance from the marketplace. So maybe there's more people here that have more information, but I'm wondering those enhanced subsidies that were supposedly put in place because of the pandemic. I don't recall the marketplace premiums being so unaffordable before the pandemic. And is that correct? It's like, how did those premiums escalate so much with those subsidies in that 5 years? don't know if anybody has an answer to my
That's a
question.
great question, and I wondered myself. People weren't arguing 5 years ago that health insurance was unaffordable, but now all of a sudden they're getting mailings indicating that their premiums are going up by 100%. Why? Anna, you were about to say something, I think.
Well, yes. What the government should have done during the pandemic is prohibited insurance companies from raising their prices, which they didn't do. And so as a result, what the government did is yes, the consumer, him or herself, did not feel the weight of the increased premiums because the government was paying for that increased premiums all along. And the insurance companies just kept profiting and putting more and more money into their pockets. In fact, billions and billions of dollars. I'm losing which government agency actually looked at how much, but it has been in the billions of dollars per year, like $28 billion, something like that the insurance companies have been making. So the during the pandemic, they should have just said, okay, insurance companies, you can no longer raise your prices. That's it. And then they wouldn't even have had to enhance the subsidies, but they enhanced them so that people wouldn't have to continue paying the higher and higher prices, which have continued to climb and climb and climb and climb and climb, like for everybody else, right? And that's why today we see that, oops, now it's going to be 114% more than they were paying before. But the problem with these subsidies is that they were always money-making project for the private insurance company, always.
Right. That's my thoughts too. I thought, what other industry does that, subsidizes for-profit companies, that, but then I thought, other than this industry, but then I thought, well, no, there's big oil, there's Boeing. I think
Yeah,
that's how we do capitalism in America. Anyways.
yeah, exactly.
Well, we're at the top of the hour and honor everybody else's schedule. And thank you, Lloyd, so much for this very concise, enlightening presentation.
Thank you, everyone, for attending. And I was very pleased to hear all of your thoughts and suggestions. And let's keep fighting.